Good afternoon. My name is Dr. James Galvin. I'm the director of the Comprehensive Center for Brain Health and the Lewy Body Dementia Research Center of Excellence. I want to welcome you to our educational conference. Today I'm going to talk about Lewy body dementia, which is the most common disease you may have never heard of. So I thought before we would start talking about the disease, I would share a little background. So there are a number of people in the news that have developed Lewy body dementia, and you may be familiar with some of them. For example, Robin Williams, or Estelle Getty, who was from Golden Girls, Al Arbor, who was the coach and general manager of the New York Islanders during their dynasty in the late 1970s, Ted Turner, a media mogul, Jerry Sloan, a basketball coach for the Utah Jazz, Bill Buckner, the first baseman for the Boston Red Sox, Casey Kasem, a very famous radio personality, or Dina Merrill, a famous actress. This gentleman you may not know much about. His name is Donald Featherstone. And you say, who is Donald Featherstone? Well, the clue is in the picture. He is the inventor of the pink lawn flamingo. All of these individuals died of Lewy body dementia. But I thought maybe I'd make it a little bit more personal and talk about my very important person who had Lewy body dementia. This is a picture of my grandfather, and he's holding me right after I was born. So I grew up in a two-family home in New Jersey, and my grandfather lived upstairs, and we were very, very close. In my junior year in high school, he developed Lewy body dementia. And I got to watch somebody I cared about very much slowly succumb from the disease. So as I mentioned, here's him holding me when I was newborn. Here is him serving as my sponsor during my confirmation. So we're very, very close. And so for me, understanding Lewy body dementia and addressing it has become a very, very important part of my personal and professional life. Now, Lewy body dementia is probably the most common disease that many people have never heard of. It's in fact the second most common cause of dementia after Alzheimer's disease. It includes two different diseases, dementia with Lewy bodies and Parkinson's disease dementia. Now the main difference is in Parkinson's disease dementia, the movement disorder develops first, and then the cognitive or memory and thinking symptoms develop later. In dementia with Lewy bodies, it could be any other type of presentation. So cognition can come first, behavior can come first, sleep disturbances can come first, as long as the motor disorder doesn't come first. Then it's dementia with Lewy bodies. Now, we know a lot about this. So roughly about 3 to 7% of all dementia cases likely have Lewy body dementia, and it's more common in men than it is in women. The combined sum of people who have Lewy body dementia is about 1.4 million Americans. Now, if you try to put that in perspective, we can talk about some disease you may be more familiar with. So, for example, there are about 1 million people with multiple sclerosis. There are about 800,000 people a year who have a stroke. Brain tumors of any type occur in about 700,000 people. Muscular dystrophy occurs in about 250,000 people. Huntington's disease, which you may have heard of, is a very rare disease affecting only 30,000 people, and amyotrophic lateral sclerosis, or Lou Gehrig's disease, affects 12,000 people. So even though you're much more familiar with some of these diseases I just mentioned, in fact, Lewy body disease is much, much more common. It's not only the second most common cause of dementia, it is the most expensive cause of dementia. We have approved drugs that only address symptoms of the disease, although they're not specifically approved for Lewy body dementia. But the direct cost of caring for people with dementia with Lewy bodies is approximately twice that of Alzheimer's disease, costing about $31.5 billion per year. And the estimates suggest that the people who are living with Lewy body dementia will increase to over 14 million people by the year 2050. Now, we have criteria today to help us make a diagnosis. So this is the third version of the criteria that were published in 2017, and I was fortunate to be part of this consensus conference. So we have to have a dementia, that is a change in memory and thinking functions that interfere with everyday abilities. Now, what's interesting in Lewy body dementia is, in fact, memory itself may not be the first domain and often isn't the first domain to be affected. It's more commonly due to attention, executive function, visual spatial abnormalities, and then you have to have other features. So I'm going to talk about each of these features in a little bit, but just to briefly introduce them here. You need to have fluctuating cognition, which is a change in alertness and attention, recurrent visual hallucinations, typically of little people or furry animals, and these occur early in the disease, REM sleep behavior disorder, so this is acting out one's dreams, and then features of Parkinsonism, slowness, stiffness, or rest tremor. And then there are a number of other features that are supportive, so they help us when we're making the diagnosis, but they're not specific enough to make the diagnosis based solely upon these features. And these are things like depression, falls, anxiety, constipation, etc. In today's world now, we have biomarkers. These are biological markers of disease that help us firm up the diagnosis. So for example, we can have a scan of the brain called a DAT scan. This is a dopamine transporter. It's a nuclear medicine scan, and we can see changes of this occurring in people who have Lewy body dementia. We can have changes in certain heart scans called myocardial scintigraphy, not commonly done in the United States, and a sleep study where we can see this REM sleep behavior disorder can help us make the diagnosis. Now, there are research criteria not only now for just dementia with Lewy bodies, but actually the prodromal stages, so the pre-stages of dementia. And so these are where we find one or more of these clinical features that develop years before dementia. So for example, Parkinsonism may occur years before people become demented. REM sleep disorder may appear decades before people develop dementia, and chronic complaints like constipation or changes in the sense of smell can occur years before people develop dementia. So recently, we've now defined these 3 different presentations of what may signify people who will go on to develop Lewy body dementia. And in particular, I want to focus on mild cognitive impairment due to Lewy bodies. So this is when we're seeing someone and the patient may have a concern, or the family member may have a concern, or the clinician may be detecting something, and we see objective evidence of changes in memory and thinking functions, but everyday activities are fairly well preserved. And then we find 1 or 2 of these core features: the fluctuating cognition, the hallucinations, the REM sleep disorder, or Parkinsonism. Now, we've done a number of studies, and in fact, when you look very carefully, look back in time, so using hindsight, 2020, in fact, there were a lot of clues that suggest that both people who start out with Parkinson's disease and people who start out as healthy controls, if they're developing Lewy body dementia, either the Parkinson's disease dementia version or the dementia with Lewy body version, that maybe 2 to 4 years before we make a diagnosis, they are in fact changing, right? And these provide very valuable clues because we can start to look back at these preclinical and prodromal stages. And if we can do this really, really well, then we might be able to intervene before people develop symptoms. And I want to talk about some of the approaches that we're developing here at the Comprehensive Center for Brain Health. When we look at people at autopsy, we can see that there are very major differences in the brains between people who have dementia with Lewy bodies, people who have Alzheimer's disease, and healthy controls. So on the top panel, we have pictures from the substantia nigra. This is the seat of the dopamine neurons in the brain. So the substantia nigra means dark substance. So in the panel that's labeled Alzheimer's and control, you can see a very dark line. But in the Lewy body dementias, you can see that that line has faded, which means those cells have died. They're no longer there. So we have a loss of dopamine, which contributes to both the behavioral symptoms as well as the motor symptoms of the disease. In the bottom row, we have pictures from the hippocampus. Okay, so the hippocampus is the seat of short-term memory in the brain. In the middle panel, you can see the arrows pointing where the Alzheimer brain is, and there's tremendous loss of that hippocampus. This hippocampus is often one of the first areas affected in Alzheimer's disease, but you can see that the person with dementia with Lewy body, their hippocampus looks a lot like the healthy control. So there are very subtle differences we can see on pathology that we may also be able to see on MRI. So on the panel to the right, we can see the MRI of a person with Alzheimer's disease and with dementia with Lewy bodies. And again, what we can see when we're looking at this is changes in the hippocampus that are much greater in the person who has Alzheimer's disease than in dementia with Lewy bodies. So we can use the MRI as a biomarker to assist us in making diagnoses. Right below the MRI, we have pictures of these DAT scans, these dopamine transporter nuclear medicine scans. Now, normally, all of that dopamine that's produced in the brain, almost all of it goes to a part of the brain called the basal ganglia. This is the part of the brain that helps us move smoothly. So it helps us start a movement and carry out a smooth movement. And so when we image this, it kind of looks like a comma. So in the healthy control, you see this comma-shaped structure. And that's normal. Right to the right of it is a picture of a DAT scan for a person who has dementia with Lewy bodies. And you can see that we lose part of that basal ganglia. So now it looks more like a period instead of a comma. And that's diagnostic of a person who has some underlying Lewy body disease. So now we have a biomarker for MRI, we have a biomarker for DAT scan. So we can use these both in research settings and in clinical care to help us make better diagnoses. We talked about a lot of the symptoms, but sometimes it's really hard to put them in perspective. So many physicians may know about the diagnosis of Lewy body dementia, but have trouble actually making the diagnosis. So when I'm teaching physicians and medical students about the disease, try to put the symptoms into buckets, because that's sometimes the easiest way to think about it. So in the middle of this picture, I actually have pictures of Lewy bodies, and you can only see these under a microscope. So at the present time, we have no way of seeing a Lewy body in a living person. We're getting close, and I'm going to talk about some of the research that's being done in a few seconds. But when we think about how we approach this to make a diagnosis, we have these group of symptoms that are the motor symptoms. So this is slowness, stiffness, imbalance, and falls. People may have a tremor. They may shuffle when they walk. They may have jerk-like movements called myoclonus. In the cognitive symptoms, we have changes in their visual attention, their visual tracking, their visual perception. They have trouble initiating or starting things. And when you time them, they have a lot of trouble. They break down. They can't move as fast as someone who doesn't have Lewy body dementia. Now, if you notice, the first couple of things say visual. So often patients with Lewy body dementia may first present to their eye doctor because they think their glasses aren't working. But the eye doctor soon realizes that they can't correct the problems by changing the lenses. Then we have the behavioral bucket. The behavioral bucket includes things like hallucinations, hearing or seeing or smelling things that are not there. You can have delusions, which are false beliefs. The most common delusion is something called capgras. This is when someone's been replaced by an identical imposter, often the caregiver. You can have changes in mood, anxiety, depression, apathy, the loss of interest. And we have this REM sleep disorder, acting out dreams, and this cognitive fluctuation, variations in attention and alertness. And then we can have these constitutional symptoms. Now, these are the most challenging because these often begin years before the other symptoms, and so they're often dismissed because you can't really put them all together. But people complain about a loss of smell. They have chronic constipation. They have changes in their urinary abilities. So they may have incontinence. They have runny noses. They have drooling. They can feel dizzy or lightheaded when they stand up. They have abnormal sweating, so temperature regulation problems, and they may have sexual dysfunction. Because in fact, Lewy bodies occur not only in the brain, but they can occur anywhere in the body where there's nervous tissue. So it occurs in the wall of the bladder, in the wall of the heart, in the wall of the colon, in sweat glands. So all these different areas can give you the different symptoms that we're talking about. And initially, if you don't really think about it, it can be very confusing to make a diagnosis. The other thing we can do is when we're examining people in the office, we do lots of pencil and paper tests. The reason we do all the pencil and paper tests because the pattern of how people change between all the different tests help me and other physicians make the diagnosis. So we can develop profiles. So the profile of dementia with Lewy bodies looks very different than the profile of Alzheimer's disease. So these tests are critically important to helping us make the diagnosis. So we use this both in clinical care and then during our research projects. So how useful is it then to get a diagnosis? Well, I already talked about that DLB is a very expensive disease. It actually may cause more disability than we see in Alzheimer's disease. And so the quality of life for someone living with dementia with Lewy bodies may be much worse than people who live with Alzheimer's disease. So it's so important to make an early diagnosis so we can make the correct choices of management and provide services and support for the patient and for their family caregivers. One of the challenges, though, is that when you ask people about the experience in getting a diagnosis, there's a real challenge. So about 78% of patients with dementia with Lewy bodies are diagnosed with something else first. Now, sometimes they're diagnosed with Alzheimer's or Parkinson's, and while that's not entirely correct, it doesn't really cause a problem because usually you're starting therapies for Alzheimer's or Parkinson's, and then eventually a diagnosis will be made. But up to 25% of the time, an entirely wrong diagnosis is made, like a diagnosis like geriatric bipolar disease or geriatric schizophrenia, which essentially doesn't really happen. So in fact, people are potentially exposed to medicines that can cause them harm. About 2/3 of the patient needed to see 3 or more physicians for up to 18 months before they finally got a diagnosis. And nearly all the time, it was a neurologist that made the diagnosis. Now, if you live in a city like, well, in South Florida, where there's lots of neurologists, that's not a big problem. But if you live out in the mountain areas, like Montana, there are very few neurologists, right? And so it can be a real challenge for some people to get a correct diagnosis. So I just want to share some research now. So one of the things that we've done is we've developed a tool that clinicians can use to help them make a diagnosis. And this is called the Lewy body composite risk score. So basically what we did is we studied people who had Lewy body disease and followed them till they died. And then we confirmed that they actually had Lewy body disease. And then we went back in time and looked at what were the presenting symptoms. And from that, we created this tool. So this gives us a statistical probability that Lewy bodies are contributing to the problem that people have. And if you answer 2 or more of the questions yes, it's highly likely that Lewy bodies are present. Colleagues of mine in England developed another toolkit, which they call the Diamond Lewy Toolkit. This is a little bit longer, but does the same basic principle. It's lots and lots of questions to help clinicians make better diagnoses. There are also some really exciting research findings. So one of the things that we found is that while we can't see Lewy bodies in a living person, we can measure the abnormal protein, and that's called alpha-synuclein. That's the protein that causes Lewy bodies. There are some new assays that are allowing us to measure this in spinal fluid. And 2 different papers that have come out in the last few years have demonstrated that we can do this in people who are living with dementia with Lewy bodies and people who are living with that prodromal stage. And it does a very good job of separating people who have Lewy body dementia versus people who do not. And now there's actually a commercial company that can offer this as a clinical assay for people who want to get a diagnosis. But it requires a spinal tap, and many people don't want to do spinal taps. Another option is doing a skin biopsy. So we can do these little punch biopsies, and we can look for these abnormal synuclein aggregates in the biopsy. Now, this is still largely a research tool, but is beginning to have some clinical use as well. So in this panel, these are fluorescent pictures. And so you can see that the red and the green is demonstrating both the nervous tissue, and on the red are the actual Lewy body aggregates. And when you overlay the 2 pictures together, you can see that those Lewy body aggregates are in fact inside nerve tissue that's inside the skin. So another really exciting tool. But of course, that requires a biopsy of the skin, which everybody may not be so thrilled about. What we've been doing here at the Comprehensive Center for Brain Health is working with commercial companies to try to develop blood tests. So in fact, we are now able to measure alpha-synuclein in the blood. So we can't do this clinically yet. It's not an approved clinical test, but in our research projects, we're hoping to be able to fine-tune these assays. And in fact, when we compare people with Parkinson's disease to normal controls, there's a significant difference in the amount of synuclein in the blood. And that synuclein increases as the motor symptoms get worse and as the memory symptoms get worse. So we're able to perform what we call differential diagnosis based on looking at Alzheimer biomarkers compared to Lewy body biomarkers. And this is a main focus of a lot of our research. Now, I want to share with you right now all of the currently approved treatments for Lewy body dementia. If you'll notice, the screen is blank because there are none. In fact, everything we do is what's called off-label treatment. So we have to borrow medicines from other diseases in order to treat the symptoms of disease. So there's a great unmet need to treat people with Lewy body dementia. But we can use medicines. For example, we can use the medicines for Alzheimer's disease to treat the cognitive symptoms, or the medicines from Parkinson's disease to treat the motor symptoms. So we can offer things to people, but it's not specifically tailored to the disease they have. So the need to do new clinical trials, and this is a top priority at NIH, to try to promote clinical trials in Lewy body dementia. I'm part of a work group that's written papers trying to optimize the design so we can design a good trial that's likely to work. And the reason that's important is because the trials that have been done have largely failed to show a benefit. And it may not be the problem with the drug, it may be the way we're measuring how the drug works. So we need to come up with better ways of doing this. What I'm really excited about is in conjunction with a company called Cognition Therapeutics, we were just awarded a $29 million grant. This is the largest grant ever given for a Lewy body dementia clinical trial to test a brand new compound called CT1812. And what this does, this is a first-in-class molecule which disrupts the ability of alpha-synuclein to aggregate so that it can't form Lewy bodies. And so we are now beginning this phase 2 trial across multiple sites in the United States to test 120 people living with dementia with Lewy bodies to see if we can reverse the disease. So to summarize these findings, Lewy body dementia is a very common cause of impairment. Okay? DLB and PDD, the two types of Lewy body dementia, differ only by what comes first. The criteria we have are highly specific and are correlated very strongly with the changes that we're seeing in the brain. There are currently no approved treatments for DLB and only one medicine for PDD. That means there's millions of Americans that just aren't being met by their needs to develop new drugs. We only have off-label treatments that only address symptoms. We've been lucky to just get the largest DLB clinical trial grant to date to myself and to Cognition Therapeutics to begin to address this unmet need. So we at the Comprehensive Center for Brain Health are spearheading really novel and innovative and creative approaches to improve our delivery of clinical practice, improve our ability to diagnose, improve our ability to change the lives of our patients and their family caregivers by developing and testing new medicines and new diagnostics. I want to thank you for your attention, and I hope you enjoy the rest of the conference.